Today's guest sits at the intersection of medical science, research, and women's health advocacy. Alice van der Schoot has a background in neuroscience and is now a doctoral researcher in nutritional science. She is also the founder of Ditto Daily. Ditto Daily is a women's health brand built entirely on evidence-based research and clinical trial rigor. It was founded to close the gap between what science already understands about menstrual health and the outdated or ineffective advice women are still being given. Since launching, Ditto Daily has seen strong market traction and raised pre-seed funding to expand its research and product range, backing Alice's mission to translate cutting-edge academic science into accessible, trustworthy solutions. What really stands out to me is Ditto Daily's social media presence. Every post is science-backed, data-led, and clearly explained. As someone who genuinely loves data and evidence, that level of care builds real trust, and it's one of the reasons I was so keen to have Alice on the podcast. Alice has been vocal about the links between hormones and ADHD, the gender bias in diagnosis, and the way women are so often expected to mask symptoms rather than be supported. In this episode, we explore how hormones interact with ADHD, why conditions like PMDD, endometriosis, and hypermobility so often overlap, and what urgently needs to change in women's health. Alice, welcome to Owning Space.
Thank you for having me.
So, to start us off, could you explain to us how hormones interact with ADHD in women and how these symptoms could fluctuate so dramatically across a menstrual cycle?
Yeah, so I think it's probably important to set the scene here that the first study that was ever published on how the menstrual cycle impacts ADHD was in 2018.
Right.
So that just shows you how far behind we are and how overlooked this is. Mm-hmm. But it did show something quite interesting. So throughout our menstrual cycle, there's the hormonal fluctuations, and at 2 points, we have an estrogen drop. So that's just after ovulation, and then again in the week before the period. And at these 2 points, there's been, in the study showed a twofold increase in ADHD symptoms. And it was specific to the time as well. So the drop in estrogen after ovulation was linked to increased risk of impulsivity and risk-taking. And then the drop before the period in the premenstrual week was linked to increased attention difficulties.
Oh.
Yeah, it's interesting, isn't it? And so the premenstrual difficulties are actually termed premenstrual exacerbation. And the reason it's happening is because ADHD involves dopamine dysfunction. Mm-hmm. So there's differences in the functioning of dopamine in the brain. And dopamine parallels estrogen. So when estrogen drops, dopamine further drops and then exacerbates everything. Mm. And it's also the reason why a lot of women with ADHD feel like their medication stops working or is much more ineffective in that week before their period, because it sort of can't keep up with that extra neurochemistry going on. Again, the research is so behind. We only have one study on that. It involved 9 participants.
Just 9?
Yeah. And they actually tested increasing ADHD medication dose just for that week to try to sort of offset the effects. And there was a real improvement in mood and other symptoms that occur premenstrually. So ADHD specific differences and then also premenstrual symptoms. Similar compared to the other weeks, but that isn't well known. And I feel like if there was more research, it would be much more accepted that doctors could do that adjustment for women and help make their lives easier.
Yeah, I mean, we'll go into this in more depth later on because I've got a whole section about PMDD. But there's so much, and I don't know what the word is, but it's like either taboo, it's just like it's lack of education. Because I don't know about your Instagram algorithm, but I get targeted about like in your luteal phase, don't do this or do this in your ovulation because you'll feel sexy and you'll feel better about yourself. And firstly, is there much truth in that when it comes to just a woman's cycle? So would you say that in the luteal phase, like why does it get such a bad rep? And is that because of the estrogen drop that you've just spoken about?
Yeah, it's because of the hormonal changes basically impacting our neurotransmitter functioning, our ability to stay focused. A lot of people get brain fog as well. And yeah, it does get a bad rep, but it doesn't mean that we should be locking ourselves away and we're fragile in the luteal phase and we shouldn't get on with our life. Like,
don't leave the house.
the thing that needs to happen is we need support systems and management options set up to help support us in that time. And our world isn't set up to support how we fluctuate, basically.
And I know I mentioned PMDD. There must be a lot of confusion with the difference between PMDD, ADHD, and PMS. And I wondered if you could talk to us about how a woman potentially, if she is experiencing these kind of highs and lows or a difference in mood, is the best thing to go to your doctor and just tell them what your symptoms are? Is it to keep a diary of those symptoms? Or like, how does that person know which condition it is, basically?
Yeah, it's definitely good to track very detailed tracking. So even things that you don't necessarily think could be related might show that you're struggling with a particular condition. The other thing is when you articulate it to a doctor, tell them how much it impacts your life. So don't just say this symptom happens, but say it's so bad that I can't complete my work for the day, like one simple task for the day, or I'm in so much pain, for example, if it's to do with period pain, that I'm like vomiting.
Yeah.
So that's really helpful because you only get 15 minutes, if that, and to just explain how severe it is so that they listen. But there is a problem that often people can go very prepared, so prepared, and still they're not listened to. So there's a problem on that end as well. It's not the fault of the individual.
Yeah, and I think in that, I know I'm speaking quite broadly here, but I think there's an issue with people potentially thinking it's normal. You know, it's like, oh, before my period, feel a bit moody and I feel a bit weepy. I know I think that as well. There's definitely a couple of days where I just want to cry and eat chocolate. But recently, I've been eating bars of chocolate every day. So I don't know what's going on with my hormones. So maybe I should love chocolate that much. But I feel like tracking it does help. But I do think that there's so much, and we'll explore this further, that needs to be done about the difference between these conditions as well and how people can seek help. Why do you think ADHD in women is getting recognised so much, when women are so much later on in their lives after years of burnout, anxiety, and being told that they're just, coping badly with things?
Yeah. So they do slightly overlap, but I'll start with ADHD in women and then go into this overdiagnosis narrative. So first of all, there's some very interesting stats in studies that the ratio of diagnosed young boys to girls is 3-1, but then in adulthood it's 1-1. So it's showing you that there is an underdiagnosis of women when they're younger. And it's interesting to think about because often the reason that it gets missed is because when a young boy has ADHD, their behaviours are noticeable. So they're disruptive, bouncing off walls. It gets them noticed. Whereas young girls are often the space cadets, the daydreamers. They very much internalise their difficulties. And because I don't know, it's a big question whether that is because of the biology directly results in different presentations or whether it's a result of social conditioning. So if a young girl is disruptive, it's seen as very unacceptable. The sort of notice me behaviour is deemed much more unacceptable in a young girl, whereas young boys seem to kind of get away with it more. So I feel like they feel like they have to be helpful and compliant, and therefore internalise their symptoms, and it gets missed and then will present differently because they're just sort of having a very inward struggle. And so that's why I think it does get missed and then is diagnosed much later.
I think that's so interesting. And I wonder if, long term there needs to be more education within schools and within teachers to pick out or spot these kind of traits. But I was in school in the, sounds so old when I'm like in the 90s, but when I was at school, at primary school, I was like a daydreamer. And I don't think I did have any naughty tendencies really. But again, as you say, maybe I masked it, or maybe I felt like I couldn't do it in case I got told off and then I'd be more upset. But I think I'd go through some lessons without just like remembering one fact, not because I didn't, now I know it's because I have ADHD, but then I would come around to, write sitting exams, and I was like, I don't remember anything. Like, no shit, I don't, because I wasn't listening. But when I put my mind to academia and actually forced myself and was like regimented with timings and revised, then I could understand things, and I could understand, like, I did well in my exams and I went to a good university and things like that, but I had to really push myself to do that. And I think it's really sad because there is a blow up of late diagnosis. I was diagnosed when I was 36, only a couple of years ago. And I don't know if other people have felt like this who are listening, but I kind of was in denial for a while. I was like, yeah, sure, okay, whatever, I've got ADHD. And then I kind of ignored it for a while. I did a lot more research into it. And I was like, this is so validating. This diagnosis is so validating for me. It makes so much more sense. And say when I didn't do well in tests when I was very little or in primary school, it wasn't my fault. And I think there's a certain level, and I hope other people feel like this, that it is validating and it's empowering now, but there needs to be something done about this diagnosis.
Yeah, definitely. And when you were saying about the sort of not listening, right? So the same I don't really like using the word symptom, like it's just like a difference. But so not listening and getting told off for in class might result in an eruption of irritation and frustration in a boy, whereas with a young girl, it will be they'll feel worried and anxious about it. Yeah. So that's where the sort of like reactivity to how it's interpreted can be different. So it's an interesting one to think about. But later on as well, there are stats that around 75% of women with ADHD get misdiagnosed with anxiety or depression.
Really?
Because it's sort of a result of the underlying thing that's going on, if you know what I mean.
Yeah, and I think, there's a certain level of, if you do go to your doctor, this is what I found in the past, it's like, oh, she's depressed, here's an antidepressant. And more often than not, actually I say more often than not, but often this might be a way of masking something which is underlining, like a root cause of something. Earlier, we were talking about estrogen. So I wanted to ask about the role of estrogen and progesterone in dopamine regulation. How do they work together? And is there any like cool, quick ways that we can kind of fuel that either via supplements or naturally?
Yeah, so it's interesting because the estrogen mechanism is fairly straightforward. It's when estrogen drops, dopamine is dropping, and then the activity of dopamine in the brain areas that sort of help control our functions like attention are impaired. With progesterone, it's much more complicated. It depends on so many different things. It depends on whether it increases or decreases dopamine, depends on what brain region, how much estrogen you have alongside it, the timing. So it's not a simple answer to progesterone. But that study that I spoke about earlier that looked at symptoms across the menstrual cycle, they did also measure progesterone. And the thing that came out about that was that in women with ADHD who had higher progesterone, the effect of that estrogen drop on inattention before their period was slightly attenuated, so like it reduced. So yeah, but that's the finding, but it's really hard to pinpoint with progesterone. Nothing's ever that simple. The brain is so complicated, and even this estrogen and dopamine theory, there's probably a lot more to it than we know.
Is there a way of getting that level of hormone inside you in like, could you take progesterone tablets, for example, if you have ADHD, and would that in theory make you feel better? Or as you say, it's just too complicated?
I think it would be a bit too complicated. The other thing is with hormonal contraception, for example, it's actually associated with a 6 times higher risk of depression in women with ADHD when they take hormonal contraceptives, the oral forms, compared to women without ADHD. So that is interesting in itself. To think if we start trying to manipulate our hormones, is that manipulation then going to affect our neurotransmitters more?
Is that because that's synthetic, right? So you're taking something which it's not your real estrogen, and then your body's essentially a bit confused?
So you're basically stopping the natural hormonal fluctuations of the menstrual cycle. So although you're stopping the estrogen drops, you're also stopping the estrogen rises, which are the ones that make you feel much better. So it can end up sort of flatlining you and making you feel really flat and depressed. I think that's where it's coming from.
Right.
Yeah.
Okay. Over the last 4 or 5 years, there's been a big blow up of ADHD diagnosis, as well as people wanting to be diagnosed and paying privately. Can you explain to us why you think that is, particularly for women trying to get diagnosed later on in their lives?
Yeah, so there's a lot of messaging at the moment, like it's trendy to have ADHD, everyone's got ADHD now. And I do think it can be really harmful because there could be a lot of people struggling who would like to get a diagnosis, but they feel ashamed or embarrassed to go and get it because they think they're jumping on a trend. And it can be really harmful to live with unmanaged ADHD. So 1 in 4 women with ADHD will attempt suicide. They're 2 to 3 times more likely to have alcohol or substance addiction.
Really?
And so I think that there's increased awareness of ADHD, and I do think more people are getting diagnosed and going to seek that diagnosis. But I do think we should trust in the diagnostic system for it. And if someone's been diagnosed, they have it. And I don't think that there's an issue with like lots more people getting diagnosed, because it's just there's more awareness. Yeah. Women are getting diagnosed later, there's more awareness of it in women. But the more harmful angle is to be saying those kinds of things that make people feel ashamed to go and seek a diagnosis.
Yeah, I agree with you. I think it's also, I wonder if there's definitely more traits of ADHD that are not spoken about as much online on a classic social media post. And when I say a classic social media post, it's like, I've definitely got ADHD because I interrupt people, or I've got rejection sensitivity and things like that, which are so true. But I think there's different traits that people might not be aware of as well. So I think it's sometimes detrimental if someone thinks they've got it, but they might not. They might just like interrupting, or they might just have a
Yeah.
lot of things to say. So as you say, I think it's very important to actually seek that actual diagnosis, and then and then you have a treatment plan. Then there's a plan from there.
Yeah, definitely.
So I'd love to talk about masking a bit more, and this idea of like a high functioning woman. So women with ADHD are often described as high functioning. So from your perspective, what does that masking actually look like in a woman?
So masking can show up in a lot of ways. Turning up absurdly early to everything because you're so terrified of being late. Sort of nodding and smiling through meetings when your brain is completely elsewhere and then frantically having to catch up later. Spending weekends just at home because you're so exhausted from getting through the week of masking. Relationship difficulties because you sort of have nothing left to give when you get home from work. And I think this all comes from the sort of the observations and adaptations that are made by seeing what others do and trying to mirror that. And it's just completely exhausting.
I mean, amen to that, because there's so many things that you've said from that list. And I was like, I do all of them apart from getting to things early. I don't think I've learned. I don't think I mastered that. I think I either get to places bang on time or I'm 5 minutes late. It's exhausting from my perspective. And what you said about staying in at the weekends because the week's been so heavy, or there's been so much kind of like grinning and smiling through things, I really feel that as well. We mentioned it before, and that the whole thing about rejection sensitivity as well. Do you think that plays a part within masking, in the sense when you speak about relationships and kind of keeping those relationships going, friendships, romantic relationships? Do you think that's associated with people with ADHD and kind of like maintaining those things in their lives?
Yeah, for sure. It's like self-protection from feeling that rejection sensitivity. So you want to be a perfectionist, you want to people please, because I mean it's where perfectionist shows up as error prevention. So you're so terrified of making a mistake that you'll sort of check over a message like 20 times before you send it. And then that shows up in your work, like checking over things. And it's perfectionism to avoid the absolute disaster of making a mistake. But it's actually really error prevention.
Yeah. And I think equally, when you spoke about, checking emails or pieces of work, like I think over time, if you do that on a daily basis, that does lead to burnout.
Yeah.
And then people wonder why so many women get burnt out. And I know that this isn't because all women with burnout have had ADHD or something, but I'm just saying in this scenario with ADHD, a lot of women tend to burn out quicker. Do you think that the healthcare system, this is a biggie, the healthcare system unintentionally rewards masking? And I guess when I say healthcare system, society as a whole.
Yeah, I don't think it's unintentional. I think it's systemic, like decades of systemic failure. So if you are struggling and you go to your GP appointment, you're employed, you can articulate yourself well. In that 15 minutes, it doesn't ring enough alarm bells. It's not showing what's going behind the scenes with panic attacks and breakdowns.
Yeah.
And so it's easier just to think you're fine, you're not struggling that much. And I do think it's rewarded. Yeah.
I think it's also sometimes easier, and it's too overwhelming. I wonder to say things out loud, and it's easier just to keep it inside because it's just quite an overwhelming condition.
Yeah, definitely.
So I would love to talk about PMDD now, for many different reasons. One mainly is I don't know enough about it, and I've heard so many people, I've had so many people request this, from an episode point of view, because no one's talking about it enough. So I would love to talk about PMDD and kind of the hormonal sensitivity which comes along with that. So it's widely misunderstood, as we know, and minimized. And a lot of people I've heard as well call it bad PMS. So can you explain medically what PMDD actually is and how this actually differs from PMS?
Yeah, so PMDD is a distinct diagnosable psychiatric condition. So it's in the diagnostic manual under depressive disorders. And to explain what it is, so it's a cyclical hormone-based mood disorder where someone will have really debilitating emotional and psychological symptoms in response to normal hormonal fluctuations, and they typically occur. It can either be throughout the whole luteal phase, so for kind of 2 weeks, just the premenstrual week, and it can sometimes disappear as soon as the period starts or linger for a few days. And it's characterized by marked depression, anxiety, anger, self-deprecating thoughts, feelings of hopelessness, and it is that it's been reported that 34% of women with PMDD have actually attempted suicide. Wow. And it devastates lives. And what's going on in the brain is really interesting. There is evidence on this. So first of all, differences in certain neurotransmitter systems, and secondly, in brain structure. So I'll go through them. So let's talk about the neurotransmitter systems first. So in particular, GABA. So GABA is our calming chemical. It's so important. It's what kind of puts the brakes on, helps balance out our mood, make us feel more steady. And in PMDD, it's been found that in the luteal phase, that symptomatic phase, there is a lower expression of a particular subunit of the GABA receptor in the brain. So GABA receptors are made up of different subunits like puzzle pieces. And the way that they work is they rearrange their subunits to adjust how much GABA can calm our brain down. So just before the period, when progesterone drops, GABA receptors are supposed to upregulate so that we can have a balancing out of a calming effect. And if that's not happening in PMDD, that hormonal drop basically just causes chaos and our brain can't calm itself down.
Right.
Is probably the best way to put it. And it's also that GABA receptor expression, the lower expression of it, is correlated with higher activity in a part of our brain called the amygdala, which is all about like heightened emotions. So the first is the GABA system. The second is the serotonin system. So in PMDD brains, again in the luteal phase, there is higher binding of serotonin. And that basically means that more serotonin is binding to the presynaptic neuron. So it's being uptaken more and less is available in the brain. So that's what's going on with serotonin. And that's correlated with worse depressive symptoms, the higher serotonin binding. And then brain structure differences. This was a fascinating study. So researchers undertook neuroimaging of women with PMDD and controls who didn't have PMDD and found that there were actual differences in brain structure. So in certain areas of the brain to do with things like emotion processing, logical thinking, motivation, decision-making, goal-directed behaviour, there were smaller volumes in those areas of the brain compared to women without PMDD. And then they got they showed an AI tool images of PMDD brains versus control brains, and it could then, based on these differences, distinguish who had PMDD and who didn't with 74% accuracy.
That's mad.
Yeah, so this is early.
Incredible.
Yeah, it's early studies, but it shows it's not just being dramatic. There's a real neurobiological, measurable thing going on, and it deserves medical attention and support.
I mean, firstly, from a research point of view, and that gives me hope in the sense that it is measurable, in like we're moving in the right direction, and these kinds of things are starting to happen with AI, and that's great. One question I have is people who get diagnosed with PMDD, is there, so you spoke about the luteal phase. So would we say on average it would affect women essentially for like half their year then? So basically half their cycle, they would be in a state of their GABA isn't regulating, their serotonin isn't as high as it could be. And then all their kind of chemicals are off balance. So that's a huge chunk of a woman's life. That is just, it's insane that nothing, we're not speaking about this as much.
Yeah, and I think actually it's worse than that even, because it's often reported by women who have the lived experience of PMDD that even the sort of week to 2 weeks, depending on how long their cycle is, that they are not symptomatic, they are dreading, they're just living in constant fear of that luteal phase then coming up. And also because of the self-isolation, the difficulties that come along in the luteal phase, they then have to sort of play catch up in that bit where they're okay. So they'll be like, oh, I have to make that plan, see that person, organise a holiday. And then I think that this is one of the reasons it often gets misdiagnosed as bipolar, because once out of that luteal phase, it's not just like normal functioning, it's scrambling to do everything that it comes across as like then going completely manic. And so unless it's tracked and seen to be cyclical, it can often get misdiagnosed as bipolar. But that constant dread then also makes those other weeks really difficult, and the aftermath of arguments, job loss, often people want to break up with their partners, leave their job, and dealing with the aftermath of all that when you feel like two different people is really tough.
I think it's that decision making that you're speaking about, but that is, it's the scenario when someone is tracking their cycle and they know their hormones and they know when their period's coming. But say if there's someone who doesn't know their cycle that well, and they're getting all these symptoms and they don't even know what PMDD is, they might just be in this position of just thinking they're either depressed, or they might have bipolar, or they just might not know what's going on with their body, which upsets me so much, because if we don't talk about PMDD and the symptoms and kind of it explained clearly as you have on this podcast, like I don't understand how women, there must be a vast majority of women who just don't know what's going on with their body, and that makes me so sad.
Yeah, and the stats for how many struggle with this is 8% of people with a menstrual cycle.
Right.
And I do wonder if it could be higher because of the lack of awareness and not knowing that that's what you have. And for it to affect that many people and for support to be basically non-existent is just so unacceptable.
Speaking of lack of awareness, it gives me a great segue into endometriosis, which we know is so under-researched and not spoken about as much as it should be. I know things are changing of late. I hope they are. I would love to talk about the connections, because PMDD, ADHD, endometriosis are sometimes kind of linked or put together. And I kind of want to understand that a lot more, because there's a lot of heightened hormonal sensitivity with all of those conditions. So from your perspective, do they link, and why is that?
So there are some links between these conditions in the research. So women with ADHD are much more likely to have PMDD. So the rates of PMDD in the general population are around 8%, but in women with ADHD, 45% of them have PMDD.
Wow.
Yeah.
So nearly half of them, that's crazy.
Yeah, so it disproportionately affects them. And I feel like with research into this, we're always at the stage where we establish a link and then there's theories as to why, but it's not like a proven thing, it's just theories as to why. So I'll go through them. The first, they all make a lot of sense actually. So the first is because when you have ADHD, you're getting that premenstrual drop in estrogen that then affects your dopamine and things get harder, and you're already in a more vulnerable position for the impact of hormonal shift to then have a massive impact on your mood. So you're kind of starting from a lower baseline. It's much easier for the hormonal shift to trigger mood symptoms, so you're more likely to suffer with PMDD. And the thing is, they exacerbate each other when you have both. ADHD is exacerbating the PMDD and vice versa, and it's really hard to then untangle them and think about what's going on. And then there are also links to trauma. So there's weirdly a lot of studies on PMDD and trauma. Like a lot of areas of PMDD need to be studied, and this one has been focused on quite a lot, so we have quite good evidence for it. So one study found 83% of women with PMDD experienced early life trauma. And what's interesting is when you experience early life trauma, at that point when your brain is still developing, the trauma creates this sort of inflammation, this ongoing systemic inflammation that can actually alter how your brain is functioning. And then this can have a lasting effect into later life. And with ADHD then, women with ADHD are significantly more likely to have experienced multiple traumatic events in their childhood. And so there seems to be the possibility of this shared pathway of trauma and how it leads to neuroinflammation and then affects how our brain is functioning in response to hormones in the future. And both PMDD and ADHD are found to involve neuroinflammation as well.
And when we say trauma, do we mean, firstly, is that just within childhood? And secondly, are we defining trauma as kind of just like a significant memory, or is this, or do you mean physical? Like, would it be physical or emotional or both?
It's been found to be physical, sexual, and emotional abuse.
Fine, okay.
Yeah. And the studies in linking it to early life trauma make sense because then your brain is very plastic and it can have a lasting impact.
Yeah.
When trauma is experienced when you're a bit older, it's probably actually more likely the other way around. Like, it's not influencing the development of PMDD. It's as a result of like medical trauma, being dismissed all the time, having to deal with this horrible condition.
Yeah. Okay, that makes sense. Thank you. Why are SSRIs so often offered without deeper hormonal investigation and tests?
So this is something that I feel I'm going to go into the entire medical treatments for
Please
PMDD.
do. I love it.
Yeah. So the first and second line medical treatments for PMDD, which are presented to us as established evidence-based care and put in the medical guidelines, actually have very inconsistent efficacy in the most recent reviews for them. So the one that you're asking about is SSRIs. So they fail for 43% of women with PMDD.
Really?
So that's almost half. And the reason is because we've discussed earlier the biology of PMDD. It doesn't just involve serotonin. It also appears to involve GABA and neuroinflammation. So if you're just targeting one pathway, that might not work for a lot of people. Then hormonal contraceptives are often given, and these have been in general shown to be effective at reducing premenstrual symptoms, but specifically not premenstrual depressive symptoms, which is the most debilitating part of PMDD. So that overall effect is likely coming from the more physical symptoms. And then the final one is chemical menopause, so another hormonal treatment. So often women are put into chemical menopause, so given medication that basically stops their body producing the hormones for the menstrual cycle. And that comes along with then menopausal side effects and massive bone density issue risks that need to be really carefully monitored. So then add back hormones are given to sort of replace these hormones and stop those menopausal effects and the bone density risk. But then the most recent review of 11 randomized controlled trials found that there's actually insufficient evidence that by giving the add back hormones to decrease the side effects, that it actually helps. In one study, it made it worse. It made PMDD worse by doing that. And that's what's in the guidelines. So it's a state really, because women with PMDD don't have options, and it's so difficult to treat a condition that involves hormonal sensitivity with hormones. There's also studies showing that some with PMDD are sensitive to progesterone, some are sensitive to estrogen, and some are sensitive to both. And that study, they basically suppressed hormones and then gave each one back separately and saw if symptoms arose. And for some, the symptoms came back with progesterone, for some with estrogen. So it's very different. PMDD doesn't seem to be a one-size-fits-all condition. There seems to be a lot of different underlying biologies. So it's a mess really, and more needs to be found out about it so that we can more effectively manage it.
Well, I think it just it's so layered. It's overwhelmingly layered, and it just sounds like there's that the hormones that are being given or the drugs that are being given, they're giving more side effects, or they might be tackling one part of this huge complex puzzle, and I think ultimately, like all these synthetic pills or going on the pill and things like that, that could potentially make things worse long over time. And it's so sad again, because obviously GPs, normally a woman would go to their GP about this, not a specialist. And if they're lucky, they would, potentially see a really knowledgeable gynae. But more often than not, they'll probably see their GP about mood swings or mood fluctuations, where, and I'm saying this from my own experience, I've been offered antidepressants probably about over 5 times in my life. And I'm like, no, that didn't work for me. I don't want that. And they're like, well, take this one then. Like, they really, no fault of their own, but they're like, they push it on you, or they go, well, have you tried the pill then?
Yeah, and they come along with so many side effects. That it just feels like for them to be just sort of offered here and there, and playing Russian roulette with it as well. Like if someone's already got so much psychological distress because they're suffering with PMDD and the high rates of attempting suicide, to give that person something that might make their symptoms worse shouldn't be a light decision.
No. Particularly when it's, affecting so much of your brain chemistry and the chemistry in your body, as well as waiting 3 or 4 months. Often I have felt worse on the pill, let's say, for example, and I've been told no, to carry on going, like 3 months, 6 months, and in that state of bad mental health, it's that you don't want to carry on. So I find it really sad, but I just think a lot needs to be done about it. Can you speak to us more about PMDD and the link between PMDD and endometriosis, please?
Yeah, so a study at the end of last year, 2025, came out looking at medical records of those with endometriosis and seeing what conditions were more likely to be comorbid if you have endometriosis. Shockingly, there were 600 conditions that you're more likely to have if you have endometriosis.
Cool, good.
One of them was PMDD, and if you have endometriosis, you're 5 times more likely to have PMDD than someone without endometriosis.
What was that stat again?
5 times more likely.
We said 500 times, and I was like, oh my gosh, so we definitely have it. Okay.
Yeah, so the link directly between endometriosis and PMDD isn't something that's been studied, but there's a sort of roundabout link. So we spoke about how if you have ADHD, you're more likely to have PMDD. If you have endometriosis, you're more likely to have ADHD than someone without endometriosis. If you have endometriosis, you're twice as likely to have ADHD. So by them both being connected to ADHD might be how they're more likely to then occur together, if you know what I mean. It's kind of like a 3-way link.
Yeah.
The connection between endometriosis and ADHD is a really interesting one because a lot of people will think, how? Like, they're so different. They're just really different conditions. How on earth can having endometriosis and ADHD be linked? And I think there's often this thought that the brain is separate from the body. Like, we already know that if you have endometriosis, because of the nature of it being a whole body condition, that you're more likely to have autoimmune disease, for example. It's no different for the brain, what's going on in the brain. And again, we have the link and theories that haven't been proven. But the theories are, first of all, inflammation. Obviously, everything with endometriosis seems to be linked to the chronic inflammation, and ADHD is linked to neuroinflammation.
Right.
So that chronic inflammation could be a link there. The second is genetic risk. The third is an interesting one, that possibly prenatal exposure to toxins can affect the development of the endocrine, immune and sort of neural systems. A much more controversial one, but it has been recommended by researchers. And then the third is this estrogen dopamine connection. So we know that estrogen is endometriosis is an estrogen dependent disease, and then we know that estrogen impacts dopamine. So could there be something going on there?
Yeah.
The thing with that is, even though women with endometriosis have an estrogen dependent disease and the estrogen is needed for that endometriosis to grow, they don't actually have higher circulating estrogen usually. So that estrogen is local to the endometriosis lesions.
Right.
So that wouldn't quite make sense in how it's reaching the brain and then impacting dopamine if it's staying local around lesions. So that's something that's been suggested to be investigated, but more needs to be done to sort of know if that's like a plausible link.
That is so complex.
Yeah.
It's so fascinating and interesting, but it's so complex for, someone who loves this kind of chat. Like, I thrive off this, but even hearing about it, I'm just like, it's just so, there's just so many different parts to like hormones and that hormone regulation. And even what you were just saying about estrogen, it's not like, okay, if I go for a blood test, I'm low in estrogen. It's not like, okay, here's the estrogen pump. Because like, that's not going to top me up in the right, like the theory is like, okay, give the person the hormone she's lacking. But more often than not, like we know, that won't help and that create different side effects. And it's just mad.
Yeah, exactly. And I want to mention something really important here, because some doctors say that the reason endometriosis has so many comorbid conditions is because someone with endometriosis is more likely to be going to the doctor and using in healthcare settings, and then conditions are more likely to be diagnosed because they're in the healthcare setting all the time, wondering what's going on, and then they're more likely to receive many labels.
Interesting.
However, this massive study on the comorbid conditions actually controlled it in a way to give us insight into this. So they compared people with endometriosis and their comorbid conditions to other people who still visited healthcare settings just as much. So they had other conditions that meant they were in that setting just as much. And so having those extra diagnoses wasn't due to difference in healthcare visits, like more healthcare visits. It was truly to do with the endometriosis, which was such an important insight, because I think that can be really invalidating, that messaging.
Yeah. So thank you so much, because I didn't know enough about PMDD, and now I know. I feel like you've given me such a brilliant answer. And we've spoken about ADHD, and I know that's under obviously the umbrella of neurodiversity, but can PMDD be linked to autism as well?
Yes. So there's been about 4 studies on this, which is interesting. So around social media, you might see stats that 92% of women with autism have PMDD. That stat is shocking and gets lots of likes and views a lot of the time. But actually, when you look at the study, the population that they were studying were people with autism and also learning disabilities. So they had Down syndrome, brain damage, hydrocephalus. So this wasn't actually representative of the average autistic person, because there was a lot more going on. And that stat is really high though. So it shows you when you also have other things going on, you're really likely to have PMDD as well. When you look at the studies that are in autistic people who don't have a learning disability or brain damage, the figure is more like 20%. So it's still double than what we see in the general population of people with a menstrual cycle. So still higher rates. And again, it's to do with the differences in, like, you're in a more vulnerable place, that autistic people really value a sense of stability. They have a lot of sensory differences, emotional regulation difficulties, and when hormonal shifts occur, you can lose that sense of stability, and it completely exacerbates everything and leads to meltdowns and difficulties in coping. And it's, again, like ADHD, you're starting from that more vulnerable place, and so the hormonal shifts are more likely to affect you, is the leading theory for it. But yeah, it's still in autistic people, there's higher rates of PMDD, but it's not like everyone. It's not that 92% that you see everywhere, probably just due to the design of that trial. So I just wanted to make that one clear, because it can also then leave autistic people who don't have PMDD feeling like, what? Like, if 92% of people have it, why don't I have it? Am I not autistic? Maybe because I don't have it. So I think it's really important to get that stat right.
Yeah, and all these conditions, so PMDD, ADHD, autism, and even endometriosis, are they fundamentally like the nervous system is out of balance? Would you say, would that be right for most of these conditions, that the nervous system isn't regulating in the right way, and then it kind of floods your body with kind of different signals of, this, you need to, flood this person with heat for a hot flush or something like that? Is that, logically, is it mainly down to your nervous system?
I think that's a really interesting question, because it's made me think about how I feel like, because I've studied neuroscience, it taught me everything about the body, because our body is full of a nervous system. Like, it affects every different system. So in whichever way it's affecting the person, all these different conditions, it will always involve the nervous system.
Yeah.
So I do think that that's a really interesting point to make.
And the reason I ask it is because I personally have been trying to regulate my nervous system more so, because I do have diagnosed ADHD, diagnosed endo and adenomyosis, and on the scale of EDS. And I do a lot of breath work and, just things that are meant to align your body again. And I do feel the benefits of it with my symptoms after. So I do wonder, I love learning about the nervous system, because it must be that it's the anchor of a lot of these conditions, or it's, partly due to.
Yeah.
So I'd love to talk a bit more about the nervous system and how this kind of might relate to different conditions. So we're hearing more about conditions like EDS, so Ehlers-Danlos syndrome, particularly amongst women with ADHD, PMDD or endometriosis. From a scientific perspective, what patterns have you been seeing?
There's a lot of patterns here, and I'm going to be rolling a lot of stats off in this, but let's start with Ehlers-Danlos and ADHD and autism, actually.
Okay.
So 46% of people with Ehlers-Danlos syndrome have ADHD and 39% have autism. So there are higher rates, and it's probably actually more than that due to underdiagnosis. And there's a few theories again as to why. So when you have Ehlers-Danlos, your connective tissue is different. And that affects you throughout your body. They're the more well-known effects. So joint hypermobility, stretchy skin, blood vessels being very weak. But it can also affect your brain. Your brain isn't just like floating neurons in space. It's got a whole scaffold of connective tissue. And there's this theory called the connectivome theory, where by having EDS, you also have connective tissue differences in the brain that affect your neural structures, and then it affects brain functioning and development, and then you have ADHD or autism. The second one is to do with something called proprioception, a very annoying word to say. But basically that's the process of your body always predicting where you are in space. And when you have hypermobility, your brain can't do that so well. So your body's moving in these not so usual patterns, and often sending off alarm signals, like error signals, to your brain as it tries to predict where you are in space. And those constant error signals can make everything slightly more reactive, the nervous system more reactive, and then manifest as emotional difficulties and kind of exacerbate ADHD and autism as well. And then the third is to do with blood flow, basically. So POTS and dysautonomia. So connective tissue in your blood vessels, if there are defects with it, your blood vessels are much weaker, and the blood flow to your brain can be different. So if you're going from lying down to standing up, for example, there's a moment where there'll be less blood flow to your brain. And this happens frequently throughout the day, and can end up basically affecting the brain in terms of neuroinflammation and affecting cognitive processes, attention difficulties. And that's also another theory. And yeah, it was really interesting posting about it the other day, because it was just so validating for so many people who thought that their neurodivergence was connected to their hypermobility. And then with EDS and endometriosis, that same comorbidity study that I mentioned earlier found that if you have endometriosis, you're 7 times more likely to have Ehlers-Danlos syndrome.
Right.
Which is high. And then there have also been studies done in endometriosis finding that around 45% of people with endometriosis have joint hypermobility, which doesn't necessarily have to be like diagnosed Ehlers-Danlos syndrome. It's just hypermobile joints. And the connection there is quite interesting, like, again, theories, but it comes down to, in the scientific papers, mentions of how endometriosis cells, they release certain proteins and growth factors that actually affect collagen synthesis, breakdown, rebuilding, and whether there's kind of a shared pathway going on with endometriosis and collagen as well. And then mast cells is another one. So in endometriosis, mast cells accumulate around lesions.
Right.
And they're like immune cells. And then when they, estrogen kind of triggers them to explode and release their contents. And their contents can also break down sort of the collagen scaffolding as well. So there are some possible links there, but that's not really confirmed. We know a lot less about that than we should.
So I've got a couple of follow-ups around what you were saying about your brain and figuring out where places and joints were in space. So do you essentially mean that with people with EDS or hypermobility, because the joints are so unstable and that's not normal, your brain can't figure out what's going on? Is that kind of what you mean?
Yeah, so it gets these kind of surprise signals all the time. It sort of tries to predict something, it's not there, and then it gets a surprise and sort of aggravates the nervous system. But what I wonder about, I think the theory amongst those, I think the first and the third one I mentioned makes most sense, because you have ADHD and autism since you are born. You don't develop it later. So connective tissue, having differences in that already when you've developed before you're born means that you'll have it when you're born. And the same with sort of blood flow differences as well. It can affect you from an early age. I do think theory one is probably the one, but the proprioception kind of implies that you develop ADHD and autism because you're clumsy, if you know what I mean. And so that's actually strangely one that's talked about the most, but doesn't make as much sense in my head to the other ones.
Yeah. I mean, essentially, your nervous system is still out of whack. It's still kind of trying to, your brain is like working overtime. And I think we spoke about this when we had a call the other week, and is it kind of also like a bit of fight or flight? So your body, it's flooding. So one thing that happens to me, for example, I have all of these conditions, not diagnosed PMDD, but I do have EDS, endometriosis, and ADHD, all diagnosed. And one thing which happens to me is when I sleep, I get very hot, I get hot flushes. And I have had all the blood tests done, all the tests, but the more I have kind of investigated this and researched, and only very recently, touch wood, I'm close to a diagnosis, but I think it could be down to dysautonomia and my body potentially flooding my body at night with heat because it's in fight or flight, or it thinks something is wrong, or it could be something like POTS, as you mentioned earlier. In theory, does that fall into dysautonomia?
I think it does. It makes sense because you see in endometriosis that there's heart rate variability, difficulties with regulating temperature, and these are all autonomic functions.
Yeah.
And there really does seem to be a connection between them all, but it's sort of something that I feel has been so ignored because of the complexity of it. But it really does make a lot of sense to me that could be an underlying factor for everything, and what you've got going on as well. It seems like the most plausible mechanism, doesn't it?
And I think, just based on that, like I've given one example from me, but I know from speaking to people with EDS and endometriosis, for example, they've got similar, they have different conditions, which I don't. And it's really hard for them to get a diagnosis, an individual diagnosis, because it can't be explained. And I do think that after hearing you speak, and one of my past guests, Alex from Hypermobility HQ, this dysautonomia, it has a lot to, I just feel like it can explain a lot of different symptoms or weird symptoms. So for listeners recognizing symptoms but feeling overwhelmed by labels, how would you suggest that they think about these overlaps without self-diagnosing?
So I think thinking about it like connecting dots rather than collecting loads of labels and loads of problematic diagnoses, but actually connecting dots and noticing patterns within yourself, I feel like is a much softer way to think about it all. And I think there's also, it can be really hard when you have all these conditions can be comorbid together. You suspect you have something else and you go to the doctor and you don't quite fit a diagnostic criteria for it, but you're on the way there. So you might be hypermobile, but then not diagnosed with Ehlers-Danlos, and it can feel so invalidating. But if you have connected the dots with multiple other things going on in your body, there will be some kind of shared underlying mechanism with them.
Yeah.
And so I don't think not fitting a diagnostic criteria should invalidate you at all. I think thinking through connecting the dots and noticing the patterns is just like a much nicer way to, all of it is awful to deal with. And you can feel like you're collecting the entire alphabet at some points. Yeah. So, and diagnoses can be, they take a lot of time to process. They can be the most wonderful thing to finally receive it. And they can also be they can inflict hard thoughts like frustration and anger that you have been through so much and not had a name for it. So if you're someone who doesn't want to be collecting all the diagnoses, just connect the dots.
The alphabet. I mean, it's all the acronyms. And I think at one point in my life, not so long ago, I was like, I kind of didn't want to be diagnosed with ADHD, when secretly I was like, I'm pretty sure I've got it. I'm pretty sure I've got EDS. But it was another acronym, and it was just another thing that I was like, I've something else which is wrong with me on top of everything else. Whereas now, honestly, I feel like I'm owning it better, because there is, not always, but there's more of a treatment plan or a protocol if you do get a diagnosis. There might be medication, or there is a community that you can talk to. And I just think that anyone who is struggling to get a diagnosis, but they've started connecting the dots, like Alice has said, keep advocating, because it's so important to advocate for yourself. So I'd love to move on to what needs to change now, and how we can kind of shift this narrative. I know we've spoken about systems failure and a lot of these conditions being systemic issues, and there needs to be more education. So looking across ADHD, PMDD, endometriosis and hypermobility, what does this tell us about women's health currently and how it's structured?
Well, I think we're seeing a lot of links in the research, but the problem is when you go to the doctor, they focus on specific systems in the body, like specific organ systems, and they have their specialities. And I think that they forget to look at the woman in front of them as a whole person. Or they're just less inclined to do that because they go with what they've been taught about their speciality, and they don't take a step back and look at these links. And I think that is something that really needs to change.
Yeah, I think it's treating a woman around the symptoms, not just their blood work or what a piece of paper or what a textbook says. What would truly holistic care for women look like?
Big question, but so many layers to this. So first of all, the basics, listening to and believing women would be a great start as the first holistic point. Secondly, I think multidisciplinary teams working well and closely together because of what we just mentioned before. I also think for women specifically, taking into account the menstrual cycle within everything that's looked at, so documenting that on records, I think it's really largely ignored, and it needs to be like a key bit of information that's thought about amongst all these health conditions. And finally, now that we have all of the links with these comorbidities of different conditions, I think it's so important to have the knowledge that if you have this condition, you're more likely to have endometriosis, because it's taking 8 to 10 years for women to get a diagnosis of endometriosis. If it was flagged up that they have these comorbidities that they're dealing with, that might be recognised earlier. So I really think attention on the comorbidities and noting them down and looking at patterns of how they can flag up what someone's dealing with is a big step forward as well.
It's the ologies speaking to each other, right? It's actually having that conversation, or that education for, let's say it's a gynae, knowing more about EDS or knowing more about hypermobility joints, saying, okay, well, I've seen the way you move now, it might be good to see rheumatology. You know, it's like, why isn't anyone doing that? You know, enough. I mean, I'm sure, I don't want to say it's not going on, I'm sure it is, but there definitely needs to be some change. Where is medical education mostly outdated, would you say?
I think keeping up with the research. I think medical guidelines are often very outdated. They've grasped what they can from the research, but then the research updates and then the guidelines aren't updated. And I think often doctors are like default looking at the guidelines and giving what the guidelines say without doing their own research into what's the latest in the research. And the problem there comes from that doctors aren't researchers unless they've decided to do that on top. And it's difficult enough to store everything in your brain as a doctor from what you get taught. So to also be taught how to be a researcher and how to read research and find research and critically analyse papers is sort of another thing on top of that when they're probably already really overwhelmed. But I really think that as much as it can be taught, encouraging doctors to look into research for themselves and not just like default look at the computer and say what's in the guidelines would really help move things forward. And I think that's the outdated part. But then also there still needs to be more research. We're still at the stage of identifying links between things and only having sort of 1 or 2 studies that show it, that then don't give doctors the confidence to be able to say, we know that for certain. And it's, you're in a position of authority where you're trusted, and sort of when you've only got 1 or 2 studies, that's all we're going to have for now, but it makes it a bit difficult to know that information for sure and exert that sort of authority as a doctor to say that. But we do actually have more research than people would think, and this is something that Ditto kind of stemmed from this. The reason, like you can see from the Ditto account, last year I summarised 521 research papers into the lab videos that I do of sharing papers. That's not a small amount, and there is a lot of research that exists out there. It's just buried in academic journals and people don't know about it. And I see stats flying around like up on cardboard signs that there's more research into male baldness than endometriosis. So I've been trained very well in identifying research because I've published systematic reviews and meta-analyses, which is like the highest level of evidence where you have to know how to literature search. So I did the searches for using all of the possible terms that could be in studies for male baldness. It's called all sorts of different things versus endometriosis. There were 30,000 papers on endometriosis and only 3,000 in male baldness.
Wow.
So it shows you there is actually a lot of research out there. It's just not been done in a strategic way of thinking of the end goal of how to help people a lot of the time. And also, I think the collaborations between academics and then the business world of actually turning what you find into a solution. I think there's this sort of disconnect between those two worlds that really like hinders the progression of turning research into solutions for people.
Yeah. And I think what you said earlier about, say, a GP or a doctor not having enough research, but also, I guess, like in front of them when they are overwhelmed, when they have to know so much about every different condition, because they are, general practitioners, it will be hard for them to know exactly what to do when a woman is complaining about very specific symptoms. But I just think, and this is just my personal opinion, it's crazy that a GP can very easily give you the pill or an antidepressant rather than send you to a specialist like rheumatology or gynae or endocrine, let's say, because I'm just, from my kind of health journey, I had to fight to get referrals to rheumatology and kind of a different ology, but they were very quick to give me hormonal tablets. And I just find that really, really confusing. Yeah. And I wonder if it's because they've got some case studies saying that with my symptoms, women were, some of their symptoms improved. But I'm like, let's get to the root of this,
Yeah, it's too easy just to give you something and send you on your way than to actually investigate something so complex. And I mean, I have Ehlers-Danlos myself, and I didn't know. I had all of these things going on throughout my whole life, and I didn't know that until I went to a cardiologist who's amazing and suggested all these things I never knew could be connected to it, even though I know the research on it, and suggested that I might have it. And it just shows you how you have to have a particular, very curious healthcare practitioner, I think, and be lucky with them, who's also bold enough to actually suggest that you might have something rather than having the fear of getting it wrong.
Yeah.
And there are some out there. And I also think that it's a massive green flag if a healthcare professional says that they don't know and they'll do more research on it. I just feel like that should be something that is okay to say.
Yeah, and it's, they're human at the end of the day, but it's rather than, get you out of my kind of like waiting room or like my doctor's room, I'll ask my colleagues, let's research this together. And it's so nice that you've met a great cardiologist, but that's interesting to me because I would have thought rheumatology would have diagnosed you. And very similar story to me and POTS, for example, like I've been for a few tests and it's through a different avenue of discovering I might have it than the original referral. So
yeah, interesting, isn't it?
So we've kind of touched on it, and I'm smiling when I say this because I think this episode and with the stats that you've given us, so thank you, throughout the whole episode has given some hope. And I say that because it sounds like there are clinical trials happening and important ones, and there is research going on. So what gives you hope right now?
There are two things that give me hope. The first is that research is finally catching up to what we already know. So, I mean, every time on the Ditto account that I post a research summary, I get in the comments, thanks, but we already knew this, like in a nice way. It's like endometriosis is connected to autoimmune disease. Like people living with endometriosis knew that years ago if they have that experience, and then finally the research is catching up. So it gives me hope that research is on the way there. It's validating experiences now. We now need the next step as to why. But yeah, it just seems to catch up 10 years later to what everyone works out themselves who's got the lived experience. And the second is that I don't know if it's like because I'm just in an echo chamber, but I really feel like women are not standing medical gaslighting so much anymore. They are becoming knowledgeable. They're doing their own research into their conditions. They're printing out research papers to take to the doctor and really standing up for themselves, and sort of taking it into their own hands. And I feel like it's so powerful that that's starting to happen now. And I really hope that that leads to some change.
I agree with you. And I think and everyone does know this, but you know your body better than anyone else. So don't let anyone say that you don't have, to gaslight you. And I think for me, it took years of going, no, actually, you're going to stay on the phone with me. I'm not leaving until you actually do this referral, because why wouldn't you? And this whole